طيب بسم الله الرحمن الرحيم صلى الله وسلم على نبينا محمد وعلى آله وصحبه أجمعين. So continuing on the same theme, pathophysiological effect of congenital heart disease, pathophysiology of left-sided obstruction. Our number 4 lesion is mitral valve stenosis. Mitral valve stenosis. Again, mild, moderate, severe. This is the heart again. Tricuspid valve, and this is the area we are interested in, the mitral valve. Mitral valve stenosis can happen, as we talked just a while ago, supramitral or at the mitral valve leaflet or within the mitral apparatus, the papillary muscles, which give the chordae that hold the mitral valve. So anything from here to there is mitral valve stenosis. It can be the whole thing, just obliterated, amalgamated, or single papillary muscle like we see in Schwann complex, or abnormal chordae, whether short or melted together, or abnormal leaflets with severe stenosis and stenosis of the annulus of the mitral valve. So regardless of where it is, we will also treat it as, and regardless of the cause, the congenital cause, or congenital association in such mitral stenosis, we are going to talk about the pathophysiological effect. If it is mild mitral valve stenosis, again, a mean gradient here, we accept not the 5s that we accepted before in the atria, because that was really more of the venous channels, if you want, the left-sided venous channels, if you want to call it. Here, anything between mean of 5, probably up to 7 millimeter mercury is considered mild mitral valve stenosis. If the left atrium pressure is, let's say 6, 8, let's take the 8 plus the 7, in mild mitral valve stenosis, the left atrial pressure will be what? Will be around 7 plus the 8 will be around 15. And this is the mitral mild stenosis. Would we expect, if the left atrial pressure is 15, much effect? Yes, we would expect some effect. But again, if this is 15, then the pulmonary veins pressure will also reflect a 15. And if we know, and we have said before, the pulmonary artery pressure mean of, let's say, 12 to 18, we can take the 12 as the mean, plus a mean atrial pressure of 15, then we are going to get a PA pressure, a mean PA pressure of 27. If we add the 15 to 20 of the RV pressure, then your RV pressure with a mild elevation, an almost mild to moderate, because I've taken the higher number. Say if I take the 5 plus 8, that 13 plus 12, it will be 25 plus 20, I'll get a 45. So a 45, we agreed, it's less than 50% systemic of a usual child or an infant who's more than 3 months old, systemic pressure. That will be just a mild elevation in the right ventricular systolic pressure to around, let's say, 45 millimeter mercury. This again, if it is only mild mitral valve stenosis, what are we expect? I think you are now experts in such a thing. We will follow what would happen pathophysiologically. This obstruction now, will it limit the cardiac output if it is mild? The answer is obviously no. The cardiac output will be maintained completely. Blood pressure will be maintained. Cardiac output, whether right side to the lung or left side to the body, will be always maintained in mild mitral valve stenosis. Okay, if it doesn't affect the cardiac output, will it affect the left ventricle, whether hypertrophy, dilatation, or being smaller size? Obviously, no hypertrophy, no dilatation is actually taking away some volume from it. So it should not hypertrophy, it should not dilate. Would it limit the size of the left ventricle? No, it would not limit the size, because still the cardiac output can pass, although on the expense of elevation of the left atrial pressure. Normal left end-diastolic pressure of the left ventricle, maybe it will be on the lower normal side, nothing of any significance in a from a pathophysiological point. So if this is what was on the after effect, what would be on the pre-effect before the stenosis? Would we see any significant left atrial dilatation with mild mitral stenosis? It's very unlikely. So that pathophysiological effect is usually not there. Not much elevation. Will we see significant stagnation of the blood in the left atrium to the extent it may cause clotting and thrombic formation? Obviously, the answer is no. So the left atrium will be fine because it's not dilated. Do we expect any atrial arrhythmias in such patient? Usually we do not expect. Most of the time there will be no atrial arrhythmias because of just a mild mitral stenosis. Going in now to the pulmonary veins, would we expect any significant dilatation of the pulmonary veins? Maybe mild dilatation. Do we expect pulmonary edema, venous edema, because of the extravasation from intravascular to extravascular compartment? No, we do not expect that. We do not expect pulmonary edema. We do not expect significant rise in the PA pressure. It will be just a mild, maybe a mild plus rise in the mean PA pressure, which is quite tolerable, with no significant effect on the pulmonary arteriolar bed, not acute, nor chronic, nor permanent, with not much effect on the right ventricle, except maybe right ventricular hypertrophy, mild, if it is continued for a long time. We do not expect any significant pulmonary valve regurgitation with no effect of it, obviously. We do not expect any tricuspid valve regurgitation in such patient and no venous pressure elevation in the right atrium, nor in the superior vena cava or the inferior vena cava. Obviously, mild mitral stenosis is really acting like mild pulmonary vein stenosis, like mild supramitral or a mild core triatriatum. I didn't mention in the core triatriatum that there are some cases where actually it is not moderate to severe or severe. It's just mild obstruction, and these cases will act like mitral mild stenosis or pulmonary veins mild stenosis. Okay, so if this is mild mitral valve stenosis, any other effects? Or in congenital mitral stenosis, any other things we should be looking at from pathophysiological? Yes, if it was associated with other left-sided obstruction. The more we come to the mitral valve, the aortic valve, the coarc, the more the association becomes apparent, especially in shunt complex. You may have mild stenosis with moderate aortic valve stenosis with a mild or moderate coarctation of the aorta. One important thing in mild mitral stenosis, when we evaluate it by echocardiography, especially, we have to make sure that we do not have any change or any significant change in the left ventricular end diastolic pressure because of the associated lesions. Sometimes if we have moderate to severe aortic stenosis, the EDP or the left ventricular end diastolic pressure here will be high. And because of that, the mean gradient, which is the difference between the left atrial pressure, the pre-obstruction pressure, and the post-obstruction pressure, which is the left end diastolic pressure, left ventricular diastolic pressure, we will have a less mean. And by numbers, it will fall in the mild area. But then it is not mild because it is falsely mild because this pressure is elevated.